Today we are going to discuss about congenital adrenal hyperplasia. So what is congenital adrenal hyperplasia? Congenital adrenal hyperplasia is a group of inherited disorders. They are autosomal recessive in terms of inheritance caused by deficiency of one of the enzymes required for cortisol synthesis in the adrenal cortex. So this enzyme block leads to three major consequences. There will be decrease in cortisol, accumulation of precursors before the block, and diversion or shunting of these precursors to other pathways, causing excess deficiency of other hormones. Excess or deficiency of other hormones like androgen can be excess, aldosterone can be excess, mineral cortical, depending upon which enzyme is deficient here. So cortisol is important because cortisol, aldosterone is regulated mainly by RAS. When there will be low blood pressure, then will be RAS activation that will stimulate release of aldosterone from GFR, zona glomerulation. There will be aldosterone secretion. It is mineral corticoid. It will lead to sodium auto retention and excretion of potassium and H plus ion, and it is regulated by RAS. But this fasciculata, it releases cortisol. Cortisol is tightly regulated by this hypothalamus pituitary axis. When there will be less cortisol due to some enzyme deficiencies, that will lead to activation of hypothalamus and pituitary. When hypothalamus gets negative feedback due to low cortisol, it releases CRH, corticotropin releasing hormone. CRH stimulates the pituitary to release ACTH. Now this ACTH will come and act on the adrenal gland and will cause hyperplasia of the adrenal gland, and that is what leads to congenital adrenal hyperplasia. So now we have to discuss the pathway of synthesis of various type of steroid hormones in adrenal cortex, and the enzymes. The most common cause of congenital adrenal hyperplasia is the enzyme deficient 21 alpha hydroxylase. So this enzyme is deficient, then there will be congenital adrenal hyperplasia most commonly. Then there will be 11 beta hydroxylase. So how this enzyme comes into picture, we will discuss in the way. So first, from cholesterol to pregnenolone. This cholesterol is outside the mitochondria. It's come inside the mitochondria by a protein called star protein. So if the star protein is deficient or mutated, then we have a condition that is called congenital lipoid hyperplasia. So from cholesterol we have pregnenolone. From pregnenolone we have progesterone. From progesterone we have 11 deoxycorticosterone. 11 deoxycorticosterone we have corticosterone. Corticosterone we have aldosterone. So this step we have to remember like that: 3, 2, 1 and 1. 3 beta hydroxysteroid dehydrogenase, 21 alpha hydroxylase, 11 beta hydroxylase. So from pregnenolone to progesterone, it is done by 3 beta hydroxysteroid dehydrogenase. From progesterone to 11 deoxycorticosterone, it is done by 21 alpha hydroxylase. And from 11 deoxycorticosterone to corticosterone, done by 11 beta hydroxylase. From corticosterone to aldosterone, is done by aldosterone synthase. This enzyme will be only present in zona glomerulosa because that's where the aldosterone will get synthesized. Now this is what pathway happens in zona glomerulosa. Now let's come to what happens in the zona fasciculata. So in the zona fasciculata, this pregnenolone will get converted into 17 hydroxy pregnenolone. This progesterone will get converted into 17 hydroxy progesterone, and 17 hydroxy progesterone will convert it into 11 deoxy cortisol. It is 11 deoxy corticosterone. It is 11 deoxy cortisol, and from 11 deoxy cortisol we have cortisol. It is synthesized in the zona fasciculata. So now let's come to the enzymes. So it's like that: 3, 2, 1. From 17 hydroxy pregnenolone to 17 hydroxy progesterone is by 3 beta hydroxysteroid dehydrogenase. From 17 hydroxy progesterone to 11 deoxycortisol is by 21 alpha hydroxylase. From 11 deoxycortisol to cortisol by 11 beta hydroxylase. And this step is catalyzed by 17 alpha hydroxylase. Now we are seeing that 17 OH is added, so it is catalyzed by 17 alpha hydroxylase. So from progesterone to 17 hydroxyprogesterone, it is by 17 alpha hydroxylase. So now we have This is what takes place in the zona fasciculata. Now comes to zona reticularis. From 17 alpha 17 hydroxyprogesterone, now we have converted into DHEAS, dihydroepiandrosterone. So DHEAS, now it will get converted into androstenedione. Androstenedione will convert into testosterone. Now there will be peripheral conversion of testosterone to estrogen by aromatase, and it can be converted into dihydrotestosterone by 5 alpha reductase. Now this DHEA sulfate to androstenedione, it is catalyzed with the same enzyme. This line have same enzyme, so that is what 3 beta hydroxysteroid dehydrogenase. Okay, so this is the synthesis of sex steroids from the adrenal cortex. So this is the pathway we have to remember. Now let's go to enzyme deficiency. The most common enzyme deficiency is 21 alpha hydroxylase. So what happens in 21 alpha hydroxylase deficiency? Now you can see in 21 alpha hydroxylase deficiency, if this enzyme is deficient, now these steps will not be there. So there will be no, this enzyme is deficient, now distal to this pathway will be no there. So there will be no aldosterone. If this enzyme is deficient, then there will be no cortisol. Okay, so there aldosterone is decreased, cortisol is decreased. Decrease in cortisol, I told you aldosterone is regulated by RAS, but cortisol is regulated by ACTH. So if there will be low cortisol, then there will be ACTH level will increase. This ACTH level is increasing, it will stimulate this whole pathway, because there is no this enzyme 21 hydroxylase enzyme is deficient. When this pathway is getting stimulated by ACTH, this will not produce cortisol, aldosterone will not be produced, cortisol will not be produced, because this enzyme is required for synthesis of both of them is now deficient. But what will be produced? This androstenedione or testosterone, this sex steroids will, or androgens will be produced more, or this pathway can be shunted or diverted to that side. No androgen, no aldosterone, no cortisol, but more synthesis of androgens. So this is what happens here. So there will be no synthesis of cortisol, but there will be increased synthesis of androgens. So now discuss the clinical features. When there is low aldosterone, there will be obviously low blood pressure, and due to loss of sodium and water in urine, and there will be retention of K plus and H plus, that will lead to hyperkalemia and acidosis. So there will be decreased cortisol. Cortisol decrease can lead to hypoglycemia or shock, or increase in ACTH. So this ACTH does two things. It increases the androgens, and that will lead to increase androgen in case of a male child. That will lead to precocious puberty. Puberty will occur earlier, or virilization. That will, androgen will lead to virilization. In case of male, it will lead to precocious puberty. In case of female, if there is more androgens when the female fetus is growing inside, even if it is XX, there will be ambiguous genitalia or clitoromegaly. So this is a picture of ambiguous genitalia, there is clitoromegaly. The female vagina, but clitoris size is increased. This is your clitoromegaly or ambiguous genitalia due to increased androgens in female. So what will the, and another thing that will do is ACTH has similar structure like MSS. So it acts on the MSH receptor, melanocyte stimulating hormone receptor, and there will be more production stimulation of melanocyte that will lead to hyperpigmentation. So that will be this picture. The picture will be low aldosterone, low cortisol, increased androgens, that will lead to precocious puberty in case of male, and ambiguous genitalia or clitoromegaly in case of female. So how we will screen it? Newborn screening is estimation of 17 hydroxyprogesterone, because this 17 hydroxyprogesterone, this is before the, comes before the 21 alpha hydroxylase. If this 21 alpha hydroxylase is deficient, now the level of 17 hydroxyprogesterone will increase. So so there will be increase in level of 17 hydroxyprogesterone. So we use it for the estimation of newborn screening. So 17 hydroxyprogesterone level are increased. And then what is the treatment? Treatment is lifelong placement of aldosterone and cortisol. Aldosterone is available as fludrocortisone and cortisol as hydrocortisone. So this what will give lifelong treatment. First we start with intravenously, then we have to taper the dose and give it via oral route. And now it is dose dependent. Now we have to adjust this dose. These are steroids, so during stress we require more of that. So dose adjustment during stress. So in minor stress like infections, if this child has minor stress like infections, we have to increase the dose of hydrocortisone or hydrocortisone 2 times or 3 times. On major stress like surgeries, we have to increase the dose of this hydrocortisone or hydrocortisone which are given to this patient of 21 alpha hydroxylase deficiency. We have to increase it by 4x or 5x. Okay, so surgical correction of ambiguous scintilla in the female should be done within 2 to 6 months. The surgical correction of this ambiguous scintilla can be done in 2 to 6 months. So mother with pregnancy is at risk. Mother who have previously affected child, as it is autosomal recessive condition, if they can have multiple child, one child is affected means other child can be affected. So it is autosomal recessive condition. So mothers with pregnancy is at risk, previously affected child with congenital adrenal hyperplasia should be started with steroid therapy as soon as the pregnancy is diagnosed. Okay, dexamethasone 20 microgram per kg is started to suppress of secretion of steroid by fetal adrenals, including adrenal androgen. So in the deficiency, enzyme deficiency, fetus will synthesize more androgens. If we will give steroid from the outside, that will lead to suppression of this ACTH and CRH axis, and that will prevent further virilization of the external genitalia, and that will leading to increase in case of androgens. So now this cortisol was less synthesis, that will lead to synthesis more of ACTH, that will lead to increase synthesis of androgens. So if you give steroid from the outside, now the cortisol level is not low, so there will be no hyperstimulation of ACTH or CRH, and no more synthesis of androgens, that will prevent virilization in case of females. So first, when as if the mother has previously affected child of CH, as soon as the pregnancy is diagnosed, we have to start steroid, that is dexamethasone 20 microgram per kg to suppress the secretion of steroid by fetal adrenals. Now then Coriolis villus sampling performed to determine the sex of and genotype of the fetus. We have to determine the sex and genotype of the fetus before the birth of the fetus, of course, to know the sex. If it is female fetus, then it is more risk of developing these conditions. Okay, so if it is a female fetus, we have to continue the therapy if the fetus is affected female. If the fetus is a female, then we have to continue this therapy of steroid. If the fetus is male, then no need to continue, discontinue it, because male there will be precocious puberty, it is not a big deal, but female it will be ambiguous scintilla. So the drug used for parenteral therapies of congenital adrenal hyperplasia dexamethasone, which is avoided if the fetus known to be male or unaffected female. So this is what we know about 21 alpha hydroxylase. It is the most common enzyme deficiency. Now let's go to 11 beta hydroxylase. So 11 beta hydroxylase is required here. So if this enzyme is deficient, then what will happen? There will be decrease in aldosterone and cortisol. There should be, I am thinking there should be decrease in aldosterone and cortisol, but this 11 deoxycorticosterone, it has properties of aldosterone. So what will happen? It should have decreased aldosterone, decreased cortisol, because enzyme is here. But due to increased level of 11 hydroxycorticosterone, this 11 deoxycorticosterone, sorry, due to increased level of 11 deoxycorticosterone, this 11 deoxycorticosterone acts as a mineral corticoid or aldosterone. It has an aldosterone like effect. This enzyme is deficient, then it will be synthesized more, so it's like aldosterone is more, so that will lead to more sodium and water retention, and it will lead to hypertension. It should have been decreased in aldosterone, but effect is hypertension in case of 11 beta hydroxylase deficiency, because 11 deoxycorticosterone, which is a precursor before the enzyme, it is getting more accumulated. It is getting accumulated. It is because this enzyme is deficient, which was going to convert it into corticosterone. Now if this enzyme is deficient, it will accumulate more and more, and it has aldosterone like effect, that will lead to hypertension. So 11, there will be 11 deoxycortisol is also accumulating, it has cortisol like effect. So there will be no features of decrease in cortisol, or no, and features of excess aldosterone. So it will present hypertension, and in this case also the cortisol is decreased If cortisol is decreased, then stimulation of ACTH will occur. So ACTH will act on MSH receptor, that will lead to hyperpigmentation, and it will lead to synthesis of more of androgen, because now this is deficient, this is a deficient, pathway is diverted, so there will be more secretion of androgens. And in case of male, it will lead to precocious puberty. In female, it will lead to ambiguous genitalia. Okay, so 11 high 11 deoxycorticosterone has mineral corticoid effect. I have told you, this is the catch here. In 11 beta hydroxylase deficiency, this is the most important point. The high 11 deoxycorticosterone has mineral corticoid like action, so there will be hypertension in spite of low aldosterone. If you check the aldosterone level of this patient, there will be low aldosterone, but this baby will have hypertension because this 11 deoxycorticosterone, which has mineral corticoid like effect, and in obviously due to increased androgens. If it is a male, then there will be precocious puberty, and if it is a female, there will be ambiguous genitalia. So precocious puberty in a male with hypertension is suggestive of congenital adrenal hyperplasia due to 11 beta hydroxylase deficiency, and in increase in 11 deoxycortisol level is diagnostic of this enzyme deficiency. 11 deoxycortisol, it is used for diagnosis, just like 17 hydroxy progesterone was used for diagnosis of 21 alpha hydroxylase. Here we use 11 deoxycortisol level are used for diagnosis because it will be increased. 11 beta hydroxylase catalyze the conversion of deoxycortisol to cortisol. Therefore, in 11 beta hydroxylase deficiency, there will be increase in 11 deoxycortisol level. That will estimate for the screening or diagnosis of this condition. Now, this is the second most common is 21 alpha hydroxylase. Now we go to 17 alpha hydroxylase. So what is 17 alpha hydroxylase? 17 alpha hydroxylase coming here. It was converting pregnenolone to 17 hydroxypregnenolone, from progesterone to 17 hydroxyprogesterone. It was leading to further synthesis of this cortisol and DHT. So in now what happened? If this enzyme is deficient, now this pathway is breakdown, there will be more synthesis of aldosterone, because something will be like downwards because this enzyme is deficient. So there will be no of all of this, so there will be more aldosterone. So aldosterone is increased, so there will be hypertension, and there is decreased cortisol. Cortisol is decreased because this is not progressing, so there is decreased cortisol and decreased androgens. So due to increased aldosterone, we have hypertension in case of 17 alpha hydroxylase deficiency, and due to decreased cortisol, there will be stimulation of ACTH. ACTH will act on MSH receptor, that will lead to hyperpigmentation, and there will be now this condition, there will be also decrease in androgens. In 21 alpha hydroxylase or 11 beta hydroxylase, we have increased androgens, but in case of 17 alpha hydroxylase, there will be decreased androgens. So what will lead? It will lead to, in case of males, it will lead to under virilization. Androgen required for virilization or masculinization. So in case of male, if there will be less androgen, in case of growing male child, male fetus, there will be under virilization. So what will be the features of under virilization? Hypospadias, bifid scrotum, delayed puberty. Delayed puberty, in severe cases, ambiguous genitalia can be there in case of a male. In case of female, female is asymptomatic because female doesn't require androgens for during their time of growth. Now here androgen is less synthesized, so there will be a female will be asymptomatic, and androgen also required from some female features, because that will lead to delayed progression of puberty in case of female. Mostly it will be asymptomatic female. It can lead to slow delayed progression of puberty due to decreased aromatization of testosterone, and androgen lead to production of testosterone. Testosterone is converted to estrogen by aromatase enzyme. So now there is less testosterone, so there will be somewhat less estrogen, but it is not affected much. Female is not affected much in case of 17 alpha hydroxylase deficiency. So it is 46XY, that is a male child, disorder of sexual development, DST, genotypical male with female phenotype, because there is no androgen here. Okay, there is no less and no androgen here. So genotypical male with female phenotype along with hypertension. Genotypical male with female phenotype along with hypertension is a diagnosis of congenital adrenal hyperplasia due to 17 alpha hydroxylase deficiency more likely. Now let's discuss about 3 beta hydroxysteroid dehydrogenase. 3 beta hydroxysteroid dehydrogenase is another enzyme that is required for this synthesis pathway. So what happens in case of 3 beta hydroxysteroid dehydrogenase deficiency? So this is the 3 alpha 3 beta hydroxysteroid deficiency. So if this enzyme is deficient, then there will be decreased aldosterone, decreased cortisol, decreased androgens. When there is decreased aldosterone, there will be low BP and hyperkalemia acidosis. When there is decreased cortisol, it will lead to hypoglycemia shock and decreased androgens. Decreased androgens, it will affect only male, so it will lead to male underfertilization or undermasculization of a male. So it can be similar like genotypical male with female phenotype. But in case of 17 alpha hydroxylase deficiency, hypertension is there. But in case of 3 beta hydroxylase dehydrogenase deficiency, there will be no hypertension here. So due to less aldosterone. So male, there will be underfertilization of male, hypospadias, bifid scrotum, delayed puberty, and in severe cases ambiguous genitalia, and there will be features of increased ACTH due to decreased cortisol. So increased ACTH will further stimulate melanocyte receptor, stimulating hormone receptor, related to hyperpigmentation, and it can also stimulate for synthesis of aldosterone androgens. But due to deficiency of these enzymes, how much you stimulate all of this, due to deficiency of enzymes, it will not go further. So there will be less androgens, less cortisol, less aldosterone, but ACTH level will be increased. So in females, what will happen? Females, there are due to there will be less androgens, that can be mild virilization due to DHEA. So this DHEA, this is the catch here. So this is DHEA, what is accumulating here in case of deficiency of 3 beta hydroxysteroid dehydrogenase. It can lead to mild virilization. It has androgen like effect, so it can lead to mild virilization. Okay, in 11 beta hydroxylase deficiency, there is accumulation of 11 deoxycorticosterone, which has aldosterone like activity. Even if aldosterone was less, but there was development of hypotension like that. In case of 3 beta hydroxysteroid dehydrogenase deficiency, there is deficiency of this enzyme that will lead to decrease in sex steroid, but the precursor metabolite DHEAS is increased. This DHEA has mild androgenic effect, so it will affect the female by mild virilization. So in the older child, so what will the female develop? Acne, hirsutism, and menstrual irregularities. This will be seen in case of female. In case of acne, hirsutism, menstrual irregularities in a female with 3 beta hydroxysteroid dehydrogenase deficiency. So salt wasting is due to deficiency of aldosterone. So salt wasting is seen in 3 beta hydroxysteroid dehydrogenase deficiency, because there is deficiency of all three. And in case of 21 alpha hydroxylase deficiency, there will be salt wasting. But in case of 3 beta hydroxysteroid dehydrogenase deficiency, there will be decreased androgen. But in case of 21 alpha hydroxylase deficiency, there will be increased androgen. And on the pathway discussed earlier. In case of 11 beta hydroxylase deficiency, in spite of low aldosterone, there will be hypertension due to 11 deoxycorticosterone. And salt wasting or low BP plus ambiguous genitalia in a female, virilization of female fetus, and precocious puberty in case of male. It is due to 21 alpha hydroxylase deficiency. Salt wasting or low BP, undervirilization of male or in female fetus, increased androgen, hirsutism, acne, menstrual irregularities. It is due to 3 beta hydroxysteroid dehydrogenase deficiency. So in case of 3 beta hydroxysteroid deficiency, there is some features of masculinization in case of male, that I can't say kind of masculinization, some features of virilization like hirsutism, acne, but there will be salt wasting. Salt wasting will also be there in case of 21 alpha hydroxylase. In 3 beta hydroxysteroid, there will be also salt wasting. Hypertension plus ambiguous genitalia in a female, virilization of female fetus, precocious puberty in male. It is due to 11 beta hydroxysteroid dehydrogenase deficiency. We know the cause of hypertension in case of 11 beta hydroxysteroid dehydrogenase deficiency. Now this is the most important table: serum androgen versus salt wasting. So salt wasting is present in 21 alpha hydroxylase deficiency, 3 beta hydroxysteroid dehydrogenase deficiency. So but in case of 21 alpha hydroxylase deficiency, there will be high androgen. In case of 3 beta hydroxysteroid, there will be low androgen. Salt wasting is absent in case of 11 beta hydroxylase deficiency and 17 alpha hydroxylase deficiency. But there will be high androgen in case of 11 beta hydroxylase deficiency. There will be low androgen in case of 17 alpha hydroxylase deficiency.